Hello, and welcome to another episode of the IBMS podcast. I'm Rob Dabrowski, the editor of the Biomedical Science magazine, and in this instalment, I'm joined by Dr Phil Bryant, who is Associate Tutor in Cellular Pathology at Cardiff Metropolitan University, but has many other roles and interests. It's a wide-ranging discussion covering 60 years of change and innovation in the NHS, from poor lab ventilation in the 1960s through to at-home testing, cellular pathology, and efforts to eliminate cervical cancer. I hope you enjoy the episode. Hello and welcome to our guest today, Dr Phil Bryant, who is the Associate Tutor in Cellular Pathology at Cardiff Metropolitan University. Hello, Phil.
Good morning, Rob. Thank you for inviting me. It's a pleasure to be here this morning. I hope it will be of interest to you and your readers.
Pleasure to have you, Phil. Well, why don't we kick off? We're going to be kind of talking through the history of your career and your different roles and all those experiences. But why don't you tell us a bit about where you are at the moment and your current role, Phil, before we delve back in history?
My current role at the moment is that I am retired from NHS laboratories, which I retired in 2016, completely retired then. But since that time, I've had a few requests to go back to the university where I had done many lectures in the past and where I started studying there 60 years ago. And also, I'm doing a lot of consultancy work for a corporate company based in Wales who sort of are kitted out pathology laboratories on consumables and the like. And they wanted some promotion of some of their consumables and techniques in the US so that we could teach them things that we'd learnt in the UK that wasn't too popular in the US, which is normally the opposite way around.
Yeah.
Normally the US are way up, but the technique that we were looking at, and I just mentioned the technique in passing, but it is what they call large format histology, which is what they call whole slide or whole mount histology, is where you've got, instead of having a slide that's a conventional microscope slide size, it's twice the size. So you can have larger processing cassettes that will take up to 10 times the volume of tissue that the conventional ones will take. So that means that you could do a whole mounts. So you can actually put whole organs and whole slices of tumor and everything all in one cassette. So when you're looking at it on a 3 by 2 inch slide, you've got the full impression rather than having a series of smaller blocks, having 10 blocks or so of smaller samples, so you'd have 10 stain slides to look at. All this would be in one block. And this is what they call large format. It's known as super mega or whole mount histology. And this had been going on in the UK and in Europe for many years. I mean, personally, I think I'd been using this since the start of the millennium. So, looking at late 90s, early 2000s. So that's a long time. But it hadn't really taken on in America. So basically, I've been doing lectures in the US for the National Society of Histotechnology, which is a society out there which I'm a member of. I'm on the editorial board of their journal. But I've been doing them since, I think, 1998. My first one was out in Salt Lake City. So they are these annual conventions, but they're all over the shop. They're not sort of strictly restricted to local, just a central location. So, it's all over, north, south, east, west, even into Canada. So I've been doing them for 25 years. But up until 2016, that was sort of, I've been doing them for, say, 17 years, 18 years. In the trade show out in the US, I used to meet up with a colleague of mine who worked for this company in Mid Wales. And he knew that we'd done this technique back home here because I used to buy all of the consumables and things from the company. And, but it wasn't just us, it was through Europe. It was well accepted, this technique for larger tumor pathology. So essentially, he said, "Can you come and do some lectures for us?" So I said, "Fine." So that's how that started, even though I'd been doing them for about 10, 15 years or so before that. But I was either self-financed or but it wasn't too corporate then. So that's how that side came about. Yeah.
And how would the American, because America normally sees itself as the leader and quite often is in kind of all forms of medical technology and advances. How did they feel about someone from a far smaller country with less money?
I think it doesn't matter where you are in the world, really. Cancer diagnostics is cancer diagnostics. And if you can improve that that area of diagnostics by utilizing a single slide to look at where you've got not just a whole tumor, but you've got a whole resection margins and everything just on one slide, rather than interchanging like pathologists do, like taking one slide off the microscope stage and putting another one on. And some of these may involve sort of up to 5 to 10 blocks instead of having the one so it's certainly time consuming. And the fact is, you also get a lot of more information on one slide that you would have to gain from probably 5 or 10 slides on top. Yeah.
Yeah.
So that in itself was sort of a big driver, and they were pushing this sort of technology out to the US. The company has now been absorbed by an American company based in Texas, but at the end of the day, at the time, they were sort of a family-run business. So that's how it all started for me to do the science, the sort of the consultancy work with them, although I'd been doing it for many years on my own before then. So obviously, that really took off out in America because it was something that they didn't really know much of. There wasn't much in the way of people supplying the goods to be able to perform this technique. So the whole point of this was doing some workshops. And we've done lots and lots of workshops from short 1 hour lectures right through to, I'd done 4 hour workshops, hands-on workshops. But because we were sort of a UK company at the time, I mean, they're not now, but I mean, at the UK company at the time, all the equipment that we had to have for the practicals is we had to sort of be shipped out to the US or get supplies from colleagues out there. So that was a major move. But it was enjoyable. But these hands-on were great for the people to actually utilize the technique themselves, because you can read as many books as you want to. I can give as many lectures as I want to, but you don't get that feel for technique. So I was on doing the sort of the technical, the pathological side of the lectures, and my colleague would be doing all the sort of the consumer side and the equipment side and that type. And it worked really well,
And,
I,
and when you were going out there, Phil, would you go out there just to deliver a couple of sessions, or would it be kind of like a band going on tour where you'd arrive in America and then travel around the country delivering these workshops?
Yeah, the convention goes on for about 5 days, and if I was doing a 1 hour or 4 hour lecture, that's what would be. But I mean, during that week, there'd be lots of other ancillary lectures. There'd be over 100 lectures going on at the same time. There'd be trade shows. There'd be sort of class speakers coming out, keynote speakers. So there'd be some of them. Meet a lot of colleagues. So, and it's a good sort of forum for meeting up with people from there, and particularly those who were interested in doing a technique that they were unfamiliar with. But normally, yeah, we used to do just go and do the lectures in the sort of the locations then.
Yeah.
But I used to go wandering off after, do a couple of things. But there was one time, it was just before lockdown, I think it's about 2018. We'd started doing these lectures. I think my first one was in Orlando in 2017. And I think it became so popular that we were invited to do some state meetings as well as the convention, the annual one. And in 2018 then was the first I mean, I was coming up to my 50 years in the business, and I'd never traveled so much in my life. And then all of a sudden they said, right, we're doing, so we had to fly out to, I think flew out to Dallas and done a meeting for the Texas Society for Health Future Technology. And then from there, we moved on to Anaheim in Los Angeles to do one for the Californian Society. Then I came home for 5 days just to say hi to the wife. And I go to Chicago and flew up to Madison in Wisconsin for a Tri-State Society meeting. And then I came home from there, and then we went back out then for September for the annual, the sort of international convention in St. Louis. So that was all 1 year. And I've never had any years before that, like that before, and I've never had them since. But what you were saying is that's how much interest there was at the time, that people were showing an interest. So obviously that gained a lot of popularity then, and there's a lot of people who are utilizing the techniques that I've just spoken about. But I'm still doing them at the moment, but I think they are coming to an end now. As far as that's concerned, I did do an hour one in Long Beach in September, and that was my third visit to Long Beach. We've had quite a few annual conventions there in California. And I'm putting forward for next year, which happens to be in San Antonio in Texas. But my time is running out now. I've been in the business 60 years, and I've enjoyed every minute of it. But I'm still doing the lectures down in the Cardiff Met.
Talk us through that. What are you doing at Cardiff Metropolitan University, though?
Well, I studied in Cardiff Met. Well, it's known as Llandaff Technical College back in the day. And I started work a few months after England won the World Cup in 1966, just before the horrific disaster that happened in Aberfan, where the primary school was engulfed by the colliery spoil tip, killed an entire generation of children, 150 children killed. And I was 17 and I just started work in blood transfusion service in Cardiff. So you can imagine, I'd straight from school, I was a new kid on the block, I was just out of short trousers, but the phone call came in that there was this horrific disaster just less than 20 miles up the road. So you can imagine that all the blood supplies were sent up, yeah? But unknown to us at the time, they were of no value because there was no serious injury because these people were just engulfed by a colliery spoil tip and they were just smothered in the school. The whole school was covered in this spoil. So, that stayed with me for a long time because it was close. I mean, I was only 17, straight from school, and this major disaster. So that was how I started into the business, by doing that. And then I went to Llandaff College, or Cardiff. I say it's Cardiff Metropolitan University now. It's had a few different guises in that time. But, I started looking at doing lectures on structure of DNA, bearing in mind that it had only been discovered 12 years earlier.
Yeah.
So, I was like a new kid on the block. I look at the molecular side of work that I've been doing now and see how far we've come since those days when I was looking at the double helix 12 years after it was discovered. It's just horrific to think how far it's gone.
Did it feel like a time of real kind of advancement and promise? Because we had the recent discovery of DNA and the double helix. We've got loads of kind of social and interesting things going on with the birth control pill coming in the 60s, then the measles vaccine first, liver and kidney transplants in humans. At the time, did it feel like a time of upheaval, change, and promise, Phil, or did it just feel normal?
Yeah, it did. Certainly did. I was doing things. I done a year of A level, and I wasn't happy. I was doing the sciences, chemistry, bio. But I really wanted to get out, and this job came up in blood transfusion, and that was just right up my street. So I started doing medical laboratory sciences, or medical laboratory technology, as it was called then. So I done the ordinary national, higher national, and I done the fellowship in histopathology back in 76, I think, yeah? So in those years was my formative years, but in the early days of ordinary national, where we were looking at the structure of DNA, and it was a new era. It had just been discovered, or just in 10 years or so, it had been discovered, and I was learning the new stuff. So you really felt that you're beginning a new era in it. I would never have thought that in the time that I'm speaking to you now that it had altered in this way that it has. It was unbelievable. But that's how it was. So I had those and enjoyed those days. All my training and the experience in hospital laboratories was essentially in South Wales. And I've never had to move house for work. I did do a couple of my mini locums out in the Middle East back in the mid-80s. But they were I was still working at the time, sort of unpaid leave, that type of thing, in a military hospital in Riyadh. But that was an area of change for me when I got my first senior post after 76. But before 76, I had done studies in lots of laboratories throughout Cardiff, different hospitals. But the bigger area that really sorted it for me was the University Hospital in Cardiff, because I'd been doing talking at lectures on different topics, but when I went there, they had everything. They had things that I'd only dreamt about, like electron microscopy, autoimmunity, immunology laboratories. And I thought, well, this is the place to go. And I got a job there back in the early 70s. It hadn't long opened at the time. and I worked under the auspices of a gentleman called by the name of Bill Barr, who I'll always remember. He was a sort of a strict disciplinarian, but, he was the man I needed. I called myself the mad scientist at one time because I needed someone to sort of grab me and push me in the right direction. So down there, I learned everything from, you name it, I learned it, because it was a brand new teaching hospital. I did everything. So by the time I left there with my fellowship in 76 and I moved to Bridgend, to the Bridgend General Hospital, believe it or not, my contemporary in the Heath Hospital or the University Hospital, Bill Barr, as I mentioned just now, he was actually in charge of the laboratory back in Bridgend in the day. But Bill Barr, I mention his name because at the time of me starting out in cellular pathology, the Bible that every laboratory had was a book called Cullen. The author was Charles Cullen. He was a Canadian pathologist, and it was the Cullen's Handbook of Histopathological Technique. And it didn't matter what lab you were in at the time, they all had their own Bible, which you had desktop handbook for. And Charles Cullen died, but Bill Barr and my other colleague of mine who worked in the dental school alongside Russ Allison, they actually rewrote the book and it was called Cullen, Allison and Barr. But I worked with them and it was a great time. 5 years, but I learned so much. So I took that on. I've always been interested in teaching, training, rather than management, although management comes with the job sometimes. So when I went to Bridgend, then we had the new hospital built in the mid-80s, and that was called the Princess of Wales Hospital. Brand new hospital, So we moved up from the old Victorian District General up to a brand new hospital in the mid-80s. And Princess Diana, obviously the Princess of Wales at the time, she came and opened it. And so they were good times. So when I started in that trust back in January 77, when I retired in 2016 from Singleton Hospital in Swansea, it was all under the same trust. So I'd been with that trust all that time. The sort of the boundaries had moved a little bit and incorporated Swansea, but now the trust that I was originally working for does not incorporate Swansea anymore. It's come back to sort of whereabouts I am now. So it's just gone around a full circle, basically. But that's NHS trusts for you,
Yeah. What do you think are the most exciting advancements that you've seen in your 60-odd years?
Oh, God forbid. I don't know where to start. The funny thing is that people say, what hasn't changed? And I tell you what hasn't changed. There's only two things I can tell you that haven't changed at all, and that is the use of formaldehyde. Yeah, because that is still the fixative agent and has been since Adam was a boy. And utilizing hematoxin and eosin as a stain, as a primary stain for diagnosis. And that hasn't changed. And if you look back in all the other laboratories, whether it's hematology or microbiology, there's stains there that they're using, like gram stain and that have been around for decades, centuries perhaps, that haven't changed. So some of those haven't changed whatsoever because they're still the gold standard. But a lot of the technology, the techniques have changed. And one of the first things I remember that actually changed the way things worked was the introduction of these tissue tech cassettes, that processing cassettes that you can buy. Everybody sells them now. But in the late 50s, and I think he was a Canadian pathologist. I met him once. I can't remember his name now. Anyway, but he invented this back in the late 50s, early 60s. And now I think is a company called Sakura who sort of owns the whole gambit because it's been absorbed into them. But that was one of the major drivers because before then, people used to sort of, well, unless you know how it works in histopathology, but processing tissues in those days, you'd have to a single piece of tissue. Everything would be handwritten labels. Then you'd have to put that label in a pot with a thing. Then you'd have to embed that. Then you'd have to take the label. So, this was sort of ever prone. It was. But when these cassettes were invented and brought into the current trend, it just transformed it all because the specimen stayed with that forever, and you could write. Although they were handwritten transcripts on the cassettes, I mean, nowadays they've all got printers for these cassette label printers. But in those days, they were all handwritten, so there was still room for error. And then the other big area that really came in was the introduction of the computer. Save having day books coming in where you used to write all the patient's details. Everything was handwritten and filed and then, and misfiled. But when the computers came in and the laboratory information management systems, it just transformed everything, into an area whereby mistakes were seldom made, because of the way things were. And laboratory automation was big as well, where they had tissue processors. At one time, they used to have open processors. So they used to have what they call tissue transfer processes, where you'd have pots and pots and pots of all the bad chemicals for you, like alcohols and xylenes and benzenes or whatever. And the tissue would be transferred, lift up across to the next one and go around that way. That was a tissue transfer. So every time the lid lifted up off that, it was open to the air in the laboratory. There was no air conditioning or there was no filtration systems or nothing. And then that changed over to the enclosed fluid transfer, where all the specimens were put in one area and all the fluids were transferred inside an enclosed system. And that just transformed it all because, there was a time I used to do tissue dissection, and you may laugh at this, but I had a kitchen sink in the laboratory, and on there we used to do all the tissue dissection. So you can imagine whether it was small samples, that was fine. But when you had large samples to dissect, such as clean bowels and God knows what else, we used to open the fire door so we could get some air in. They did put a ventaxia, one of these ventaxia fans in the wall above us. That meant all the formaldehyde would be going up past your nose to get extracted.
Yeah, yeah.
But although it sounded good at the time, you were still breathing all the stuff in. And then they invented the downdraft dissection, so it all sucked it all out. So it's things like this, although they look minor at the looking back, they were major at the time.
And these advances, obviously, kind of the computerization, laboratory information management systems, and automation, all these things, they all make the job easier and faster. But back in the day, before you had any of these advances, did you have bigger laboratory teams, or were there fewer samples coming through?
That's right, Rob. Yeah. I mean, there were obviously fewer samples around because nowadays, just look at prostate biopsy. In those days, if you had a prostate biopsy, most biopsies, including cervical biopsy, whatever, were usually under anesthetic. There weren't all these biopsy techniques where you could just do them while they come out to outpatients. Some of these were sort of taking place under anesthetic. So if you had a little chunk of prostate, then, that would be a small sample. Nowadays, it's all needle biopsies, but I can guarantee you this, as far as I know, that if you had prostate biopsies, you had probably 10, 20 samples on one patient coming through, as 10 or 2 different regions of the prostate. So instead of having one little sample from a prostate biopsy, if they thought that was the area of interest, so the number of specimens per patient have really increased on modern times. So just looking at a prostate biopsy, for argument's sake, one patient can generate 20 biopsies. And you think, well, that's a lot of work. Bearing in mind, it wasn't just cut one section and look at it. All these would be cut levels, so they'd be going. So it would generate a multitude of slides on one patient. So even if you had the same number of staff as we had in those days, the volume of work has just increased tremendously now. In those days, yeah, I mean, the number of samples coming through the laboratory were sort of, fewer, obviously, but they still had the work to do and preparing them. But preparing them was a lot more difficult in those days as well than it is nowadays. But obviously, labs are kitted out more for fast flow to fast turnaround times and things, and larger teams for doing the essential parts throughout the department. So, yeah, I mean, times have changed, but obviously the workload that's generated from that. And again, when in the olden days, when it was a sample, very little immunology was done. Very little immunology. I used to have 2 blood samples and we used to look for antibody reactions for autoimmune diseases and on sort of prepared slides. But that was in those days. Nowadays, you take breast biopsies, for instance. If it's a cancer, it automatically generates a multitude of immunohistochemistry. automatically, from estrogen receptors and progesterone receptors and everything. So times have really changed, but for the good. Nowadays, not only can they say that that patient has got prostate cancer, they can tell you the exact location where that cancer is. Yeah, they can tell you exactly what type it is. They can even sort of modify the technique and the treatment for you to have personalized medicine, depending on your genetic structure of that tumor. So things have really, really changed for cancer diagnostics and cancer treatments. And a lot of these have changed far, far for the better. In the olden days, people used to have, talking of breast biopsies just now, that the only drug that they ever knew in those days was tamoxifen. And people would say, fine, that was great. They had a drug for breast cancer. But the understanding was is that a lot of these patients didn't respond to it, to the treatment, simply because tamoxifen is okay if the cancer was dependent on estrogen. If it wasn't, then tamoxifen wasn't the drug for you. Till these days where they're doing estrogen and progesterone receptors and Herceptin receptors, they wouldn't know in those days that if you had breast cancer, you had breast cancer. End of. And that was it. And this is the drug for you. So, because they didn't know what they know now, they couldn't understand perhaps why some patients weren't benefiting from that drug, where others did. But if it wasn't dependent on hormone growth, then obviously that drug was of no benefit.
Do you think to some extent the NHS is a victim of his own success? There's this constant struggle to make sure it's got enough funding, but it seems like potentially the more advanced the NHS gets, the better it is at keeping alive, the more advanced the diagnostics are, the more everything costs. So every time the NHS gets a bit better, it gets a little bit harder for the NHS, if that makes sense.
You were dead right. Finance comes into it all the time, and even in the olden days, you know, people used to say, "Oh, we're going to buy this new piece of equipment." Well, but we got no money, and they said it might not be essential for we could still manage without it, but with these things that are moving on into cancer diagnostics and molecular technology and AI and all, I mean, it all costs money. But at the end of the day, I've always said you've got to speculate to accumulate. So, sometimes you're going to drive yourself forward because the money you're going to save at the end of the day by not giving people mistreatments, yeah, and falsifying the hope of good survivals and the rest, then, you've got that side of the coin, which we never had in those days. So although it can cost a lot, and drugs cost a lot of money because they can take 10, 15 years to come to fruition. And that's why they cost so much to start with, so that they can be used at a reasonable rate and at a reasonable cost for people who desperately need them. And you know as well as I do, you know, cancer diagnostics and cancer treatments have just revolutionized, it's gone to the window, and all positive stuff, and it's growing all the time. But I take your point in that you're dead right. It all costs money, and I know people who've had to send off to America to get drugs because they're so damn well expensive over here. And that is a sad, sad time, you know? But cancer diagnostics is a big, big player, and it plays an important part of some of my lectures that I do. I'd be down in Cardiff Met now after Christmas with the undergraduates for about 10 weeks, and I do a couple of hours a week. It just keeps my old grey matter going. But I enjoy doing it, and I've written lots and lots and lots of blogs and papers, produced papers, written textbooks. And I generated a website called pathologicalbodies.com. And on that, I had 40, 50 years worth of lectures and everything. And I thought, when I retire, it's going to end up in a hard drive or in a spoil heap somewhere. So I thought, right. So what I done, I put it all together and we built some websites and pathologicalbodies.com. And there's a host of information there based on, and there's lots, and all my blogs are there on my publications page. On all the blogs are there to read on lots and lots of different topics, from the diseases of Charles Darwin to how changes have been made to the laboratory in all the years. There's loads and loads of just interesting little, well, I call them interesting blogs on different aspects. There are probably 40 or 50 blogs there. But, I still go through them, some of them, and think I should have rewritten that one somehow differently. But I still enjoy reading them because they're only sort of 5-10 minutes to read. And a lot of the times things have changed tremendously now that I need to update them, but I'm not going to update them. They were written at the time with all the knowledge that I had. I got loads and loads of books. It's all under pathologicalbodies.com, but there's a couple of links there, and then there's a tissue sampling tab, which will take you to everything there is to know about tissue sampling, from sampling methods to processing, staining, you name it. And there's lots of other interesting information. They're all there, free to use. They are quite well accepted, to be honest. I see the figures of people that accept them all around the world. And that was the whole point, I didn't want any reward. It was just, it's my legacy. And I feel that if I hadn't done it, it would have all gone by the wayside. And I still utilize some of the techniques now, But one of my big interests was HPV, human papillomavirus. And it bring me on to my PhD, really, because back in the late 80s, I really wanted to go do some further in career exams. So I got accepted to do a master's in Bath University on rheumatology, systemic lupus, that type of thing. I was accepted in the university, and I was accepted by consultants in rheumatology in Bath United Hospital. But I wrote off to the trust as it was then, and they turned me down. They said it was not relevant to pathology. And I still can't understand how a disease process isn't relevant, but that's how it was. They turned me down because I think what it was, I had to attend because I was an external student, I had to attend their 20 days a year. And they didn't fancy that. They didn't want to lose me for that time. And pay me as well. So I looked at the Open University, and I saw that they'd done external higher degrees, and that was a start. And I picked up on HPV because we'd done a lot of cervical cytology, cervical biopsies, so cervical epithelium, but we've also done a lot of bladder biopsies. And if you looked at the urothelium of a bladder and the epithelium of a cervix, there's a lot of cells, and they look at what I termed empty cells. And in actual fact, in cervical cytology, there were cells called coilocytes, and they were specialized cells. They had vacuolization in the cytoplasm. The cytoplasm was condensed on the outside of the cell, and these were called coilocytes. And the interesting thing about these was that they were the first indicator that there was a papillomavirus infection going on. This was even before you'd even detected that the virus was there, but it was a general indicator. So that really caught my eye. And bearing in mind, back in the late 80s, cervical cytology was really moving on, looking for the causes and cures for cervical cancer. And there was a gentleman from Heidelberg in Germany, Harald Zerhausen, and he was the big player back in the late 80s, early 90s. He was the big player, and in 2008, he had the Nobel Prize for linking HPV, high-risk HPV, to cervical cancer. And he was the main man, and he had a Nobel Prize in 2008. Sadly, he passed some years ago. But I wrote to him, and I said, can I have some samples of the virus, please? So he sent me some samples. So I had a couple of cocktails. And in the early days, HPV, there's now over 300 different types of HPV. Right? But at the time, obviously, you start at 1, and types 1 and 2 were consistent with sort of skin warts and that type of thing. And as you get up to around about type 6 and type 11, these were sort of low-risk types, and you found these in genital warts, right? So they were linked to benign conditions, but still linked to the genital system. And then by the time you got up to type 16 and 18, where we're looking at sort of high-risk types because of their sort of genomic structure, these were classed as high-risk types. And these were almost 80% found responsible for cervical cancer. And that was a driver. And Zerhausen had his Nobel Prize in 2008, as I said. So in the early 90s, cervical screening and HPV was massive business. Certainly in Europe, in Amsterdam, they were doing full city screening of the whole population of women who were screenable. So it was a massive event. So I thought, right, how can I utilize this? So I looked at my bladder, and I thought, not my personal bladder, but these black infections, and I could see these empty cells that reminded me of these coilocytes in cervical epithelium. So I looked at that, and then further research, and I could see that in cattle, I know I'm going back into the veterinary side now, but in cattle, there was bladder cancer, was linked to a papillomavirus known as the bovine papillomavirus. And I thought, well, that is strange, isn't it? There's me looking at human papillomavirus, and in bladder cancer in cattle, the bovine papillomavirus was partially responsible, linked in with a sort of a carcinogenic agent, which was possibly found in ferns that the cows used to chew up on the mountains, Anyway, so I thought, right, well, there's a link there. There was no mention, there was nothing linking human bladder cancer to HPV. So I thought, right, this is it. And that's where my proposal came, and I was successful, and obviously had a couple of papers published, and they were the first of their kind, linking human papillomavirus to bladder cancer, human bladder cancer. And I remember the first letter I had from the British Journal of Cancer saying, this is unusual, it's strange, we've never seen this before, and I think it'll generate some interest. And the rest is history. And there's so many publications on bladder cancer. I mean, I haven't kept up with it, to be honest. I've got more important things that I'm doing now. But because of my interest in HPV, I've been interested in cervical cancer now. And the World Health Organization, they've got a global strategy for eliminating cervical cancer worldwide by 2030, right? And you think, my God, and this was a few years ago, so they had less than 10 years to do this. And you think, well, they've got a challenge. But you think, well, okay, is it working? Well, what they wanted to do was do this worldwide. But you can only do this when you look at all the patients who are called up for cervical screening that do not attend for whatever reason. Times have changed where, you might only get a 50, 60% uptake. So the people who are being diagnosed with cancer are only less than half the amount of people who should be tested. Nowadays, they're producing these home testing kits, which is absolutely brilliant because you reach and outreaches, certainly in areas like Africa or whatever, people who can't attend these clinics, they don't exist. And they say, is it working? Well, to be honest, Australia, Sweden and Portugal are on target for elimination by 2030, right? That's remarkable. That's eliminating cervical cancer from their country. So that's utilising all these screening processes, home testing, which is big, big, big business. And the other thing is utilising, and I know it's a simple thing, is that utilising menstrual blood as a means of screening. And it is so successful, it saves all the problems that women used to have more clinics and having pelvic examinations. And so this is all changing. So all this is going to help in eliminating cervical cancer. What really surprised me that in 2011, a low-income country in Africa, Rwanda, became the first African country to implement a national HPV immunization program for girls. Immunization is a big, big, big player. So this global strategy is hopefully going to be 90%, 90-90. That's screening 90% of the population, vaccinating 90% of the population, and following up 90% of those that are positive. Rwanda is on target to become cancer-free. Yeah, that's incredible when you think of a sort of a low-income country like that. So this global strategy is working. So I'm just keeping an eye on it. So that's one of my interests, and digital pathology and AI is another big area. So, I mean, that's just a massive, I don't know where to start really,
Well, you mentioned a couple of times kind of at-home testing and remote diagnostics. Do you think that's going to be post-pandemic in the way people had lateral flow tests now? Like, oh, I can go test myself.
We all lived through COVID, and it was a tragic time. And people weren't being tested. They couldn't be tested. They were giving COVID tests, and it was home testing. And, however successful they were, people were becoming used to the idea of saying, well, I could test for this at home. That's clever. And you think, well, what else is there out there that I can be tested from at home? Like the normal routine for women between certain ages is sort of the menstrual cycle. And you think, well, there's so many opportunities for getting samples without having to go to all the traumatic visits to clinics and whatever, and sending a sample in and it being tested. And there was one young woman, it's called the PAP Cup, and I know she'd won an award. And what surprised me is that it's a simple method for women to test themselves at home, but it's inbuilt HPV tester in them as well, that will tell you whether it's positive, in the kit. And I think, well, this is the way forward, and hopefully these things will help. But yeah, I think home testing is a big business, certainly in this side. And when the World Health Organization wrote that by 2040, there will be completely elimination of the cancer worldwide. And I mean, 10, 20 years ago, that was just a dream. I mean, people would thought, you're never, ever going to do it. Not a million years. But unless you've got a vaccination program, a screening program, and a treatment program all working together, the world's your oyster.
And you also mentioned AI there as one of the things you're kind of interested in. What are your thoughts on the kind of impact that will have on labs?
Oh my gosh, yeah. One of my lectures that I do, I mean, bearing in mind, I've been retired some time, and when I was down in Singleton Hospital in the last 6 years of my working life, I was only working part-time, but I was actually coordinating the cancer research side of samples that were needed to be dispatched for cancer testing. So that was my involvement. So that's what I was managing. And I was an independent. I was doing it. I was asked to go down there. And so that was that. So essentially, in 2010 was my last time I worked in the cellular pathology laboratory or on the bench, if you know what I mean, yeah? So in the last 15 years, times have changed. A lot of the techniques I'm talking about now, I've never experienced in my working life, you know? Never experienced them. And that includes digital pathology. The closest I got to digital pathology was having a camera sitting on top of the microscope, a picture, and you'd have to develop the film, or if you were lucky, and you could have a sort of a camera on the top of the microscope and have it projected onto a wall, or big teaching microscopes where you had six people or so sitting around one microscope. That was about it. But if you wanted to share or ask for second opinions, then you had a few problems, because you either had to send a slide off to somewhere to have a second opinion, which meant that if that gets lost, is that the only case I've got without cancer in it? So there's lots of interesting areas. Now, if you had a picture of that, using old methods where you had a camera fitted and take a picture of it down the microscope, you could have a picture, but it's just like you're looking at your holiday snaps. You'd look at the picture and you could see, but digital pathology, oh my God, it has just transformed that, because just by using the mouse on your computer, you can zoom, screen, whole slide images. And I got up samples there that I show my students, and I said, look, this is what you can do with a microscope. You can zoom in, zoom in, zoom in. You can move on the stage around, yeah, to look at different areas of that sample. But essentially, every time you look at a sample under microscope for the first time, think of it as a Google Maps, right? Because if you're looking at Google Maps and you want to go to somewhere like, say Blackpool, for instance, right? You'll get Google Maps up and you'll have a look to see where Blackpool is. Brilliant. Then you can zoom in and have a closer look at Blackpool. Then if you're looking for specific areas, I usually talk about the nightclubs in Cardiff, but I don't want people to think that but but what you could do is zoom and zoom and zoom, and then you can actually see not just the street that it's on. You can actually see the focus of it on Google Maps. Microscopy is just like that, where you look at the whole picture. Look, zoom in. You're not interested in sort of benign areas, but if there's areas where you think there's cancer, you can zoom in and you go into it, and all that can be done just by using the mouse. And the quality is incredible, from high power to low power. Absolutely. I'm just gobsmacked by it all, to be honest, And these are new techniques, technology that has been around since I retired. So it's such an interest, and this AI, I'm not into computer, all this computer topography and whatever, but this AI is incredible, whereby you can train slides, but somebody has got to look at thousands and thousands and thousands of, say, a prostate biopsy, for instance. So on that biopsy, you look at thousands and thousands of slides. You look at normal cells, normal blood vessels, bit of muscle maybe, bit of this, bit of that, cancer cells, this different types of cancers. They're not all the same grade, not all the same stage. So all this is going to be trained. But once you got that trained up, yeah, you use that program. It's revolutionizing diagnostics, because what it's doing, it produces a heat map for those areas that are of interest to the pathologist, which means that pathologist hasn't got to go to all these slides, because if 95% of these slides are all benign, you haven't wasted your time as a pathologist, but you think, well, there's things I can do that those 90% of slides would have been pushed aside because there was nothing in them as far as AI was concerned. But the heat maps on those 10% that are the ones that the pathologist can specifically spend his time with.
Yeah.
So this is the way it's going. And it's just, I'm really intrigued by it all, by the way things are and the way things were. And, it's only going to be for the better, for diagnosis. And people always ask me that question, is it going to rule out a pathologist? Do we need the pathologist? And the instance of is you need the pathologist simply because they have to look at these heat maps. They're the ones that have got to issue the final report, and they can correspond then with consultants and oncologists and the like. So it's a vicious circle, but there is so much demand on pathologists now. Talking about the prostate biopsies, you get all these biopsies on one patient. You think, yeah, you got to look at them all.
Mm-hmm.
Nowadays, there is that you can rule out all this, and that the input of the pathologist is looking at things that he is trained to look for, and not that sort of 80%, 90% of work that is just sort of standard, random, benign work,
Now, I've got one last question for you, Phil. You touched on that nice phrase a minute ago, something along the lines of you're interested in how things have been and how things will be. Can you tell us one kind of favourite moment from your career and maybe look forward to the future of one thing within diagnostics in the NHS that you're looking forward to or excited about?
Yeah, well, I mentioned the World Health global strategy, and to be able to look and say you can eliminate, there's always talk of eliminating infections and things like this, malaria and things, polio, and, but cancers are very difficult to manage and to eliminate completely. But a lot of these, because they are dependent on screening, unless you get patients up for screening, you're never going to eliminate cancer. Right? So you've got to get round that problem, and by doing what they're doing, by having 100%, 90% sort of vaccination programs, because they're giving these vaccinations to school-age children, 10, 11, 12 years of age, girls and boys, before they start their sort of sexual antics or whatever, and that is great, because they're preventing it. And whether or not there is the other side of the coins thinking, well, will it make people more promiscuous? You're always going to have this talk, particularly if you're a parent, The fact is, if you can prevent them having cervical cancer by having that, then go for it. And then obviously there's the uptake, the screening, and you can sampling at home, The other thing is, people say, well, if you got the vaccine and you get sampled at home, but you're still positive, what happens to you then? Who looks at the results? Particularly out in the outer reaches of Africa, what's going to happen to my result because it's positive? Who's going to follow me up then? So there's always that side, but this is where they're looking at 90% follow-up as well of all those patients who are positive. So it's a massive, massive challenge, and cervical cancer has been a big part of my education life in uni, teaching it, and with cervical cytology and my link with my thesis, and so HPV has played a big part of my life for those reasons, and to see that happen would be great. AI will find its own, and I'm sure it'll go on 10 times better than it's gone on in the time that I've been looking at. Yeah, interesting times,
Perfect. That's a nice note for us to end on. Phil, thank you so much for joining us today and sharing a load of insights, some really interesting discussions. So thank you again for joining us.
Rob, it's a pleasure. Thanks for asking me, and have a good day.
Thanks to Phil for taking part in this episode, and thanks to you so much for listening. I hope you enjoyed the podcast, and remember that this episode can be used as reflective learning for your CPD. Please do keep an eye out on the IBMS social media feeds and websites for future episodes. Thanks again for listening.